Thank you so much for joining us for developing recommendations to improve access to care for patients taking prescription opioids for chronic pain. This is the round 2 video titled Potential Solutions to Access Barriers. As a brief reminder as to where we are, this is the Access Barriers video, which is the first step of round 2. After this video, you will attend the 90-minute virtual meeting to brainstorm recommendations and provide feedback following that in the version of Survey 2. I just want to start by saying thank you. We cannot thank you enough for taking the time to watch the first video and complete the survey. Your feedback was invaluable to informing this presentation and the remainder of the panel. So today's agenda, we will start with reviewing feedback from the round 1 survey. We'll discuss possible solutions to each barrier, including existing pain-related efforts to reduce the barrier, tools used for other diseases that could be leveraged for pain care. So we have 24 panelists across diverse backgrounds, and we're super thankful because you guys span from expertise in care coordination, payers, research makers, community and public health leaders, policy leaders. We have patients on our force and also providers. So when we asked you during the last survey what barriers contribute most or least, there was agreement amongst most of you that policy contributes the most and care coordination, if you had to pick one, likely contribute the least. Most of you found it difficult to pick one because the barriers are equally important or interrelated. You said all play an important role. They all affect each other interchangeably. It was hard to decide these two questions because all of the factors are important. All of the barriers contribute to some degree to the difficulties in accessing care for pain management. When we asked you suggestions for additional barriers, several brought up various provider and patient education gaps. Providers may not have clear, concise, evidence-based information on best practices, myths, stigma from reliable sources. We have been putting so many rules in place for providers, they may just think it's too hard or do not want to lose their license because of a prescribing error. Patient education, not aware of pain treatment options or a lack of cultural acceptance, making patients aware of providers in where there's a perception of lack of geographic availability of primary care physicians. Based on your feedback, education appears to be an underlying theme or potential solution for each of the original barriers presented. Therefore, we did not add this as a new barrier for consideration in our upcoming discussion because we felt like this could potentially be a solution under each of the above barriers. Many people also mention racial disparities, bias, social determinants of health as other barriers to consider. We know that individuals from racially marginalized groups have more issues with getting proper pain management. Providers are less likely to prescribe them opioid medications, and they may have more problems getting these prescriptions filled in low-income neighborhoods. We agree and feel this barrier is not currently being captured under any of the others we have presented thus far. We have decided to add this as an additional barrier for discussion, which we will discuss during today's session. Several of you acknowledged efforts to expand treatment for opioid use disorder, but few were aware of efforts for chronic pain treatment. I'm not aware of any. My expertise is in policy related to SUD, recovery and community services, and interventions for the justice involved. It seemed like there should be more intersection in my work with treatment for chronic pain, so perhaps the evidence of a gap. There are efforts within the justice system that will aid an opioid abuser to receive medication-assisted treatment to help them from their addiction. However, from a payment and policy perspective, I have not seen anything new as of late related to increasing access to care. Quite the opposite. I'm not aware of any efforts to help patients like Mr. B. I've only seen policy to reduce opioids, but not improve pain management. Some questions that you guys suggested that may need some more answers. Many of you raised questions about the characteristics of this patient population. I guess the main thing I think we need to ask ourselves is how did a certain population get started on a medication in the first place? Risk stratification and data on chronic pain patients, OUD, and overdoses, giving information for providers to make educated decisions on chronic pain. I think we really need to answer the question about who is misusing opioids. What are their characteristics and what factors are associated with misuse? What is the connection with knowledge, awareness, and access to other modalities of pain management? Is the use of opioids a surrogate for the lack of access to mental health or other types of treatment? We really thank you for all of your feedback. And so we are, going back to the original barriers that we had proposed during the first session: policy, payment, care coordination, and stigma. We've now also added racial disparities. While some of you suggested kind of lumping this under stigma, we do feel like there are different types of stigma devoted towards patients with pain that may not intersect with what we have seen with respect to racism and racial disparities. And therefore, this deserves its own barrier section for us to discuss focused solutions on racism. So the round 2 format, just to give you a heads up, you will be broken into small groups to discuss one of the 5 barriers presented during the in-person or the virtual session. This video today is meant to provide background knowledge of existing solutions to each barrier to inform your discussions. We want everybody to be on the same page going into these small groups in order to have a productive conversation with our limited amount of time. The examples we present here are pulled from a search across federal, state, private, and nonprofit sectors. This is not a comprehensive review of current efforts to address these access barriers. These examples are intended to help generate ideas. I'm sure we missed some examples of solutions, and we look forward to hearing about those during the in-person session. In your small groups, you will brainstorm at least 3 policies, interventions, or research questions that could reduce barriers to treatment for patients taking opioids for chronic pain. Just to give you an onset of what the definitions we're talking about, policies are a set of guidelines or rules adopted by an organization, including governmental agencies, insurance payers, individual clinics. An intervention, on the other hand, is an action or strategy implemented to encourage behavior change at a system-wide or individual level. Research questions are a guiding question, which, if answered, would allow stakeholders to better understand and address this issue in the future. So let's keep that in mind while you review the sections today so that you can think from a policy, intervention, and research perspective going into the discussion for the next session. Just as a brief review of what we went through in the background, we discussed in the first video that there are multiple breakdowns in effective multimodal pain care, from getting in the door to the primary care office, to decision-making that happens between the primary care provider and patient, to actually accessing effective multimodal treatment. So let's start with policy. So reminder, this barrier is state and insurer policies around opioid prescribing that add significant administrative burden and fear of litigation, which reduce providers' willingness to treat this patient population. So a current landscape includes national policies, whether that be the CDC guidelines for chronic pain, DEA licensing and monitoring, and as we know, many of the state of Michigan policies, including things like the Opioid Start Talking form, review of the MAPs, dose and duration limits set by insurers, and sanctions for noncompliance. So there's been some effects of COVID-19 with respect to policy. Due to COVID-19, the DEA is currently allowing providers to prescribe controlled substances via telemedicine without an in-person consultation. Now, with that in mind, I also want to talk about whether there's been efforts to address this barrier. So despite many calls from expert task forces, which we described in the prior video, we've been unable to find examples of states, insurance companies, or health systems revising or, quote, rolling back prescribing policies in response to the unintended barriers created by these policies. We do know that the CDC is currently working on a revised guideline, but this has not been released yet. Moving on to barrier number 2, which was payment. We talked about how current coverage and reimbursement structures provide little compensation or coverage for pain management strategies. So we this is actually pretty difficult information to find, but we looked at billing in the Michigan state with respect to Medicaid and Medicare, and this is effective as of January 2020. and look to see, well, how much do these services for multimodal treatment cost? So 15 minutes of massage therapy, Medicaid will reimburse at $16, Medicare $30, physical therapy, psychotherapy, and things that, aren't timed, but potentially take around 20 or 30 minutes per visit, chiropractic manipulation, and then injections. So as you can see, there's big discrepancies between both Medicaid and Medicare billing, with Medicare billing almost twice as much in many of these instances. And then on top of it, the discrepancy between kind of quick injections versus things that might take longer, such as massage therapy, physical therapy, psychotherapy. These are all services that can help individuals with chronic pain, but are reimbursed quite at a much lower rate than treatments such as injections. So, one lumbosacral injection takes an average of 20 minutes, equivalent to 77 minutes of massage therapy, 73 minutes of physical therapy, 65 minutes of psychotherapy, or greater than 5 chiropractic visits when you kind of convert it the other way. And so you can certainly understand why a lot of pain rehabilitation clinics will prioritize procedures such as injections over what are lower paying treatments such as massage therapy and physical therapy. So in 2004, so this is quite a while ago, Florida medicated piloting complementary alternative medicine and covered acupuncture, massage, and chiropractic services for chronic pain. And they wrote about this. They did see kind of improved mental health and physical function scores and reduced pain in those that received the services. Unfortunately, though, this was discontinued later due to cost effectiveness. In 2016, Vermont Medicaid piloted covering acupuncture for chronic pain. Similarly saw improved function, pain capacity to work, depression. And they also saw that 32% of patients taking opioids reduced their use. Now, it's hard to tell whether that was directly related to the acupuncture versus kind of national trends, but this was something that they found. This was also, unfortunately, discontinued due to cost effectiveness. So existing efforts to reduce this barrier, in 2018, Colorado increased Medicaid coverage of non-opioid pain management. They increased reimbursement rates for things like physical therapy. So since then, they've seen more PT providers participating in Medicaid and more PT, provided to patients. I think this really does show that reimbursement is related to what services are offered. Pennsylvania Medicaid evaluated all their managed care organizations for whether they are inhibiting access to non-opioid pain management as well. In 2016, Oregon Medicaid added coverage for acupuncture, chiropractic services, osteopathic manipulation, CBT, and physical therapy. These coverage changes affect 50,000 beneficiaries with uncomplicated back and neck pain. This was relatively recent changes, and the results are expected in 2022. Another way to change kind of payment-related policies is the use of payment modifiers. So what are modifiers? Modifiers can be added on to any visit where an additional service was rendered in order to compensate for the time to deliver that service. So it could be a surgical pre-op visit. It could be a wellness visit. But you can add on a modifier if, for example, you are discussing pain management or health and wellness, etc. So this is a kind of a billing term that clinicians can do. So in this program, Blue Cross Blue Shield of Michigan and M-Open implemented a reduced prescribing pathway program to reduce postoperative opioid prescribing. So this is around surgeon-patient counseling. So surgeons who counsel patients about opioid pain management and prescribed fewer opioids. And what happened is they could add a modifier to their visit where they did this. And during this pilot intervention, the reimbursement fee increased, and Blue Cross Blue Shield of Michigan increased reimbursement of their fees by up to 35% to compensate for additional time for counseling. So this was kind of a new modifier that surgeons could use during their pre and post-op visits. And it was interesting because this reduced prescribing pathway was used in 70% of eligible surgeries. So they did get the word out and folks used it. Surgeons completed their paperwork to receive increased reimbursement 50% of the time. And this increased from 38% to 61% over 8 months. So it was rapid implementation. And these reimbursements ranged from, almost $400 to $750 per operation. So again, this modifier discussion, led to large increases in revenue, which is probably why it was used so often. But, I do want to remind everybody about kind of the differences in payments with respect to using this modifier and taking that time to have this discussion compared to, again, what we saw with respect to PT and chiropractic visits, etc. You can also think about kind of utilizing direct incentives to change provider behavior. So a direct incentive is a lump sum paid to either a physician directly or a clinician directly or a practice when specific criteria are met. So how are these being used currently? So Blue Cross Blue Shield of Michigan currently encourages buprenorphine waivering and provision for patients with OUD by providing incentives. So if you get your waiver, you can get up to $20,000 per practice to get waivers for their prescribers and begin prescribing. There's a 5% fee increase for existing providers who already prescribe to 10 patients. And within this incentive program, they noticed there were 92 new waivers issued within the first 6 months. They also provide incentives for MOUD champions. So these are point persons for questions about MOUD. So a $4,000 flat fee plus $2,000 per office consulting the champion. And there's currently 12 POs participating after 6 months. So this is a way to really kind of directly get at physicians and clinics to change behavior. But again, this is, being used to encourage the treatment of OUD. We did not find examples of similar types of incentives being provided for non-opioid pain management. So moving on to care coordination. So care coordination as a barrier, there's a lack of coordination between providers leads to gaps in receiving multimodal effective pain care and additional burden on the patient to manage multiple opinions and treatments. So what does coordinated care involve? Care coordination models generally emphasize improved access, consistent, clear communication, partnership, and patient-centered self-management. So I'll provide some examples of some care coordination strategies that have been funded in the state of Michigan. So there's the patient-centered medical home model, which is value-based reimbursement. So practices or providers receive enhanced reimbursement for implementing specific capabilities that add value to patient care, such as having protocols in place for disease screening or offering 24-hour extended access to care. This kind of helps emphasize care coordination through PCPs and has been effective at reducing costs and decreasing hospitalizations. It's intended for all patients and not necessarily disease-specific, such as pain-specific. There's also provider-delivered care management. So this is a financial incentive for physician organizations via PCMH and care management billing codes. So this requires that the practice have a designated trained case manager, a physician champion, care plans for included patients, and is intended for patients with chronic conditions. This is a new initiative called Blue Cross Coordinated Care, where patients are identified by Blue Cross Blue Shield of Michigan and contacted by a nurse. Integrated care teams include medical directors, pharmacists, behavioral health specialists, dietitians, social workers, and they help patients follow a personalized program with nurse liaison and a specialized app. And these are intended for patients who don't have a PCP or at extremely high risk, high avoidable emergency room use or inpatient facility use. There's also Medicaid health homes. These are optional for states to implement, and it's intended for Medicaid enrollees experiencing multiple chronic conditions. And this is a model where the federal government pays 90% of reimbursement for the first 2 years, and intended to improve outcomes and reduce costs by coordinating care for high utilizing populations. And in these models, providers need to show comprehensive care management, care coordination, health promotion, transitional care, and follow-up, family support, and referral to community services. And providers can either be individual practitioners or teams of medical professionals. So currently in Michigan, we actually have health homes that are currently being used for OUD treatment and behavioral health. And in these this opioid health home model, you have to be able to provide kind of intensive recovery services, especially medications for OUD. The clinics need to have a case manager, RN case manager, an addiction counselor, PCP, psychiatrist, or recovery coach. Or, you could be a primary care clinic and provide kind of MAT plus behavioral health and linkage. And you need, similarly some staff in order to provide this treatment. Other states, have also included chronic pain in their health home models, which is currently not a pre-specified condition within the health home model in Michigan. So this is something that we found that MDHHS is thinking about in 2022, is really kind of thinking about ways proactively to address fragmentation of care, specifically between behavioral health providers and physical health providers. And really kind of thinking about it from the perspective of a whole person care. Other systems that have worked to kind of help coordinate care are kind of packed teams within the VA or stepped care models. And in these, basically, you have this home packed team, almost like a patient-centered medical home type model. And then you step up to specialty care, such as, pain medicine. And if a patient kind of fails that system, then they step up again to an interdisciplinary pain center. We've also, our teams kind of looked into physician pharmacist type collaboratives. So, a lot of primary care clinics have clinical pharmacists that help patients manage, that could theoretically help manage opioid medications for patients with chronic pain. And in other disease states, usually these pharmacists are used for things like diabetes and hypertension, anticoagulation. Pharmacist collaboration has really led to improved disease management, high patient and provider satisfaction, and reduced costs. So this could potentially be an avenue in the future as well. Michigan is fortunate to also have these Blue Cross Blue Shield of Michigan collaborative quality initiatives to really think about care coordination. And these initiatives are, consortiums of hospitals across the state that work together to collect and analyze data on risk factors, processes, and outcomes of care. And their goal is to implement changes to improve patient care access across various specialties. The funding is provided by Blue Cross Blue Shield of Michigan at the hospital administrative level, not at the clinic provider level. And while currently there's no CQI that's focused exclusively on pain OUD, some do touch on these topics tangentially. For example, MEDIC, which is focused on emergency rooms, distributes naloxone kits to emergency departments across the state of Michigan. There's also a Michigan Spine Surgery Collaborative, evaluates whether other treatments are needed for pain rather than surgery. And so, pain is being touched on through these other initiatives, but not necessarily like the main focus of one. So what are some solutions with respect to stigma? As we had discussed in the prior session, stigma around chronic pain and addiction can make it difficult for this patient population to find a primary care doctor or receive quality care. And stigma reduction is multifaceted and quite honestly, not that well studied. So, you can think about who is your audience, what is your mechanism for reducing stigma, whether it be education, contact, protest, and then the channels in which you do it, whether that be CME credits, mass media campaigns, target group interventions. So there has been work to say what actually works to reduce stigma. So there's contact-based education improves comfort and decrease stigmatizing attitudes. Positive depictions of people in recovery and face-to-face contact reduce public stigma. And mass media campaigns appear to be effective in improving attitudes, especially when you use kind of first-person narratives, and may improve treatment-seeking behavior. But I think we also need to be careful about kind of media campaigns and reflect on whether they can actually be stigmatizing or viewed differently to different audiences. This is an ad that shows one prescription can be all it takes to lose everything. So existing efforts. Michigan currently requires, from an education standpoint, 3 hours of pain and symptom management education every 3 years for physicians. Could this be updated to address stigma? And one review of online pain education found that programs yielded significant increases in knowledge about pain, did not significantly change practitioner attitudes, and had little evidence around patient outcomes for analysis. So, you do have to be thoughtful about, whether we're just increasing knowledge in general or actually changing attitudes and behavior. So other tools to leverage. So through the state opioid response funds, Michigan has created a mass media campaign to address opioid use disorder. Again, not necessarily focused on individuals on opioid therapy for chronic pain. The Washtenaw County Health Department has, similarly kind of created a media campaign around mental health services. All right, so to take a little bit of a transition, like many of you had suggested, we want to include racial disparities as a barrier. And so today we'll talk about kind of some background knowledge with respect to the barrier, and then also discuss the solutions just to get everybody up to speed. So the definition is differential pain treatment provided to patients based on their race or ethnicity. And what we know already, impoverished individuals and minorities are more likely to be uninsured or underinsured than non-minorities and those with greater incomes. Racial and ethnic minorities also have reduced access to healthcare in general and specialty care in particular. And pharmacies located in minority neighborhoods are less likely to carry sufficient analgesics than those in white neighborhoods. Blacks and Hispanics are less likely to receive an opioid medication than whites. They receive lower doses of pain medication, and they also experience longer wait times to receive pain medication. Patients who identify as Black are also more likely to have more referrals for substance use disorder assessments, fewer referrals to pain treatments, and increased urine drug tests. So why does this happen? Racial and ethnic minorities are more likely to experience miscommunication and misinterpretation about pain with medical providers. Some doctors still choose to believe that pain levels are lower for individuals who are Black than whites, or that minorities are drug seekers. And physicians are more likely to underestimate the amount of pain that individuals who are Black are experiencing. There's been some recommendations for addressing these disparities. The Chronic Pain Association recommends creating tools to consistently communicate symptoms to promote better understanding between patients and providers, increasing requirements for pain management education for providers, and providing clear standards of care that must be adhered to. Some efforts that we found, this is a telephone-based intervention that was conducted with patients receiving care for musculoskeletal pain to address disparities in the care for African Americans. And in this intervention, counselors were trained in MI, calling patients to help them develop action plans for self-management and encourage physical activity. And patients completed a workbook during each session. The study is still in progress, but the results are pending. So this is an example of kind of a tailored intervention at the level of a specific racial group or community. There's also been multiple interventions that have been done outside of the state of pain, specifically in other chronic diseases such as high blood pressure. And the things that have been shown to be effective in other disease stages is kind of self-management education, peer support, counseling strategies, and provider education. So in the state of Michigan, things that we have found that are potentially kind of reducing or addressing some of these racial disparities is that there's an executive director calling on Lara to establish implicit racial bias training requirements for healthcare providers. And I guess I want to leave the question here of kind of what else can we be doing to address these racial disparities in pain treatment. I also want to acknowledge that, a lot of folks kind of have this belief system that in some ways Black individuals have been protected from the opioid prescribing epidemic because of the decreased opioid prescribing. But, the intent of it was unjust and unequal. Everybody should receive fair and equal pain treatment and have the similar access to those treatments. And we are now actually seeing kind of more harms and increased rates of overdoses amongst individuals who are Black. And so this is a very important issue that we should be thinking critically about. So what's next? After watching this video, we look forward to hearing your thoughts about these barriers in more detail. And we specifically, look forward to you kind of processing some of the example solutions we've provided. We know we haven't been comprehensive, but we hope we have provided some food for thought. And we will be breaking you guys into small groups during a 90-minute virtual discussion where we will think about these potential solutions and develop recommendations for our state with respect to kind of what we think we should be prioritizing to address each of these individual barriers. So we really look forward to seeing you at the virtual meeting. Thank you so much.